Thank you so much for your presentation and all that information. It's really appreciated. I had a number of questions while I was listening to your talk, so I thought maybe we could talk about them.
Happy
Well,
to.
first of all, I wanted to thank you so much for saying that tube feeding is not a failure, because it really is a lifeline for a lot of families. So I really appreciate you saying that.
I think that's a very important point is I know the discussions around tube feeding are very stressful and there's a lot of guilt surrounding them. But really, I'm trying to avoid aversions. I'm trying to avoid um, stressors. We're trying to meet needs while working on skill development. Again, some of us eat to live, some of us live to eat. Finding that balance is important. And in talking to families, the most stressful conversations and the time is leading up to when we start tube feeding. And then when I see them, and we at CHOP, at least we set it up with, we do it with a team that helps set them up as an outpatient or even better as an inpatient, so we can do the teaching, equipment, supplies, etc. And then when I see them 2 weeks later in clinic, there's this wave of relief that seems to have washed over families where that fear and that apprehension and that stress have dissolved. Children eat based on their skill level if they can. They work on textures, they work on variety, they're working less on volume, but they're interacting, they're socializing, and they're meeting their needs. In the daytime, after oral feeds, for example, they may receive a bolus, and then when they sleep at night, you trickle in 20, 30, 40, 50% of their calorie needs. And it works out very well. Again, there's an art and a science to it, but it generally works out very well for everybody.
Now, when you're thinking about tube feeding, I know that selection of a formula is a factor, and you had mentioned something called, and I'm not even sure how to say it, osmolality.
Yes. So
Can you?
osmolality, basically, it talks about the concentration of a formula and how that relates to blood concentration. So things that are closer to blood concentration generally empty out of the stomach better or more rapidly than either formulas that are very dilute or formulas that are very concentrated. The fat content also plays a little bit of a role there. The protein content also plays a little bit of a role there. And that's why working with a registered dietitian is so important in figuring out what your needs are, be they a formula product or a blenderized tube feeding product, for example.
Yeah, I was going to ask you about, I know some of our families make their own formula or use a blenderized real food blend formula. So if you wanted to say a few words about that.
Sure. I mean, I have no objection to using real food blends. I just strongly feel that you need a registered dietitian to be involved in the process, because it's not as simple as taking your table foods and putting them in a blender and then feeding them to your child. There's a lot of thought that goes in, again, on the calories, the fluid content, the macronutrients, the micronutrients, the vitamins, the minerals, the salts, the sugars. And we have to make sure that we're meeting needs. And so partnering with a registered dietitian with a background here is going to be very important. And we have held workshops at CHOP, for example, that work on blenderized tube feeding, talking about composition, talking about blenders, talking about storage, shelf life, viscosity, and how to sort of manage tube related issues with those, etc. So yes, I'm a fan if it's done properly and done with a partnership with your dietitian.
Getting some expert guidance. I like that. Let's see. One of the things too is that, I mean, reflux, gastric motility, especially, I feel like families, a lot of our families undergo some kind of surgery. It might be an Achilles or contracture surgery or a scoliosis surgery, or it could be any, like a gastrointestinal problem or even a colonoscopy. And then you have the anesthesia, and you have, some of them have these consequences of the GI tract after a surgery. That's very real. I hear that a lot from different families.
So I think that's an incredibly important point. And then oftentimes if you're using opioids, those also, they're excellent for pain, but the GI tract is exquisitely sensitive to them in terms of adverse effects on motility. So again, we want to focus on doing as much in the GI tract as we can. Sometimes you need to use IV fluids temporarily, but we try to do continuous feeds in the stomach, maybe past the stomach. And we sort of ramp up as safely and gently as we can to get you back to where you need to be. Again, I think constipation is a significant confounder, and we don't think about it enough, and we don't address it as aggressively as we need to. And again, we talk a lot about anatomy, we talk about acidity, we talk about how hard, for acidity, we talk about reflux in terms of just using acid blockers, or we talk about constipation only in terms of how hard the stool is, but we don't talk about the motility aspects. And I think in little kids and in children who have neuromuscular disorders in particular, focusing on the constipation is an important part of all of this. You want to make sure that your bowels are moving adequately and frequently. You want to make sure that there is adequate attention paid to, again, the art and the science of it. Smaller feeds, more frequent feeds, less sugar, some fiber, and using either stimulants or prokinetic agents do have a role here that we do take very into account. Again, we're trying to avoid too many medications and polypharmacy and just getting by with what we need, because everything we use has a risk and a benefit associated with it. And we're always trying to balance those and reach an optimal level for you.
I heard you use that word prokinetics in your talk, and I guess pro meaning for and kinetics like movement. So is it something that gets the bowels moving?
Well, again, they're different medications we use at different levels of the GI tract. So they're medicines that I use at the esophageal level. They're medications I use at the level of stomach emptying. And again, there are not a lot of these medications available in the United States. And the efficacy of these is somewhat questionable. And then there are ones that we use for the bowel as well. So common ones I may use something called bethanechol for esophageal function. I may use low-dose erythromycin, the antibiotic, for stomach emptying. I may use stimulant laxatives like X-Lax, Senna, or Docalax for bowel. Again, you want to look at the risks and the benefits there. You want to look at whether or not you need to take breaks. You want to look at them in combination with other medications, and you may want to look at them in combination with medications that improve gastric accommodation. I think the other thing that I often would like to talk about is children who retch a lot, for example, who have volume tolerance issues. Venting is very important. So venting the stomach, if you have a gastrostomy or a GJ tube, you're able to vent. Venting can be, and there's a difference between venting and draining. I'm not a huge fan of draining, because when you drain, you lose acid and you lose other nutrients, which are very important. And if you're doing that, then replacement becomes important as well. I'm more in favor of venting, and venting can take the form of using these spheral valve bags, for example. Or another thing I like to do are to sort of use a chimney-like device. So what you do is you take the extension tubing from a gastrostomy and you hook it up to one of those 60 cc syringes. And what you do at the back end of the syringe, if I'm using this, I don't know if you can see this pen or not, I think it's disappearing into my background, but you take sort of the top of that, the plunger for the syringe off, and then you sort of hold it up to gravity. And what will happen is formula may come back in and it may bubble to let the air out. But that's a way to vent without draining. And I think that sometimes is effective as well.
I have heard from different parents that when they're venting, like, and that fluid might come out and someone's sleeping, they actually wrap a diaper around it because they're super absorbent and they keep somebody dry if you have a little gastric juices coming out or something, and it allows the venting to occur without making a mess. Speaking of venting, we have a lot of people in our community who may need breathing support, whether it's BiPAP or positive pressure ventilation, non-invasive, or sometimes even with the tracheostomy. So just wondering if that venting can help with maybe air getting in the stomach as well.
Yes, aerophagia, or swallowing air, is a very big concern in patients in general, but more common in children with developmental or neuromuscular disorders. It may be, and particularly in the setting of venting, that may happen. Yes, venting the G-tube out is a good idea. We generally recommend that children try to chew as well as they can before they swallow, so that, because if you don't chew very well, then there's the potential of more gas and bloating. We recommend that if you're using an appliance to drink, we recommend an open cup over a straw or a sippy cup as a way to swallow less air. We try not to have people chew gum, because that can also lead to more gas production. And again, gas forming foods, we try to reduce those or limit those a little bit. Those that can include foods that are harder to digest. Those may include simple sugars. Again, if you have a slow bowel, simple sugars sometimes may ferment and cause more gas. So yes, we're very attuned to gas in any population.
One of the slides, I'm changing subjects now, is one of the slides you talked about is working on a team. And we actually had worked with a team in regards to swallowing and nutritionist issues. And I highly recommend it to people if you have access to it locally. And maybe you might have one silver lining of the pandemic might be access to it, a team that's not near you regionally, but might have access via telemedicine, and that those teams working together that gave a very comprehensive evaluation, and that, like you're talking about, it's a complex process. There's behavior issues, psychological issues, nutrition issues, physical issues, medical issues that can be really managed very well in a team setting.
I agree. I think the team setting, there's no I in team, there never has been. But I think that having an appropriate team and a talented multidisciplinary team really help advance care. For example, with children with cerebral palsy, it's a matter of the sensory aspects of it, it's a matter of the mechanical and swallowing aspects of it, but it's also positioning and posturing, which are very important, and going to seating clinic or having adaptive feeding tools, equipment, which are in development and are available, are very helpful.
As an occupational therapist myself, I really appreciate you saying that.
No, I mean, I rely very heavily on my colleagues for these things. With children who have more developmental disorders, say if you have autism spectrum issues, food selectivity, texture issues, even brand specificity are very challenging, and our behavior psychologists are wonderful in helping us advance past those. To broaden the repertoire in terms of variety of food, textures of food, etc. I think you really do need a team approach. And sometimes you need intensive therapy. I mean, there are outpatient evaluations, there's outpatient therapy, and some centers offer inpatient therapy to really reach your goals. And you can negotiate those goals and move towards them. I'm concerned about the sustainability of some of these things. And I think the recidivism rate is something that is concerning to me, but I think close partnership, close follow-up, and having services available to are also very important to keep moving forward.
Well, I really appreciate all this information, and I really look forward to hearing what our questions and discussion from our audience. So with that, I'm going to turn it over to people to, and oh, the last thing I meant to mention is that you talked a lot about children, and I know you work at a children's hospital, but that our constituency actually is across a lifetime, and understanding that a lot of the things that you talked about today can apply regardless of age, and some of the concepts are applicable whether it's a child or an adult facing nutrition, feeding, and swallowing issues or gastrointestinal issues. So
I agree, and I think the clinical assessments also are very important before we just jump to imaging, et cetera, because when you talk about a condition that may be lifelong, and again, it's dynamic. Where you're functioning now may not be where you're functioning a year or 5 years or 10 years from now. Yeah. Having reassessments and reevaluations is important, and we have to be judicious with some of this line of testing because there is radiation involved with some of these tests. And having a clinical assessment and clinical guidance and judgment as to where to go next is, I think, very important. And having those relationships across the lifespan is important. It's important to have a nice transition and a partnership with adult colleagues where you can to help, move these things forward when you kind of move from the pediatric age to the adult sort of age as well.
Yeah, you're absolutely right about that. Well, again, thank you very much for your time.
Thank you for having me. It was a pleasure and an honor.